California in San Diego. His research interests are IOP regulation, aqueous humor dynamics, ocular pharmacology, glaucomatous optic neuropathy, and lipid mediators. He has published widely and received several important awards. Professor Neeru Gupta is a clinician, surgeon, mentor, and scientist. She is professor of ophthalmology and visual sciences at the University of Toronto, president-elect of World Glaucoma Association, president of the International Council of Ophthalmology, and editor-in-chief of the Journal of Glaucoma. As a scientist with the Keenan Research Center for Biomedical Science at the Lee Ka-shing Knowledge Institute, Professor Gupta directs a translational research team that has published numerous seminal scientific articles focused on the visual system injury in glaucoma. She has received several prestigious awards for her scientific contributions, leadership positions, as well as her work with nonprofit organizations. Professor Keith Martin is director of the Centre for Eye Research Australia and Ringland Anderson Professor and Head of Ophthalmology at the University of Melbourne. Professor Martin is working to develop new treatments for eye disease using gene therapy and other techniques. His other current main research interest is in regeneration and repair of the optic nerve. He is the past president of WGA. Our first speaker today is Jeffrey Liebman. Dr. Liebman is the Shirley and Bernard Brown Professor, Vice Chair, and Director of the Glaucoma Division of the Department of Ophthalmology at Columbia University Medical Center. He is a past president of WGA, the American Glaucoma Society, and the New York Society for Clinical Ophthalmology, and Emeritus Editor-in-Chief of the Journal of Glaucoma. He is the author or co-author of more than 1,000 medical and scientific papers, book chapters, and abstracts. Has lectured widely across the globe on glaucoma diagnosis and management. His research interests include glaucoma progression, glaucoma surgery, ocular imaging, and neuroprotection. The title of his talk is normal tension glaucoma a separate entity from primary open-angle glaucoma? Professor Liebman.
Thank you very much for the opportunity to participate in today's symposium. Here are my disclosures. None are particularly relevant for this talk. Glaucoma is a controversial disease. There's been more than 150 years of discussion by ophthalmologists regarding its causes and nature and progression of the disease, ranging from vascular theories to mechanical theories and a variety of hypotheses regarding it. Unfortunately, during most of this time, we've had one measurable parameter, that is intraocular pressure. This has assumed the role very often, to our detriment, of being a diagnostic parameter. The scientific literature has been focused on intraocular pressure, on target intraocular pressure, and an intraocular pressure reduction in practice. We know that intraocular pressure is dangerous as a screening tool, as perhaps 50% of patients have a statistically normal intraocular pressure at the time of diagnosis. So is normal tension glaucoma a separate entity from primary open-angle glaucoma? This is an important and complex question that affects clinical care, research, and public health. There are many factors we could consider, including IOP, risk factors for disease, structure and function of the optic nerve, and the underlying genetic causes of the disease process. So are NTG and POAG separate entities, or are they overlapping in some way? Or indeed, are NTG and POAG actually a single continuous entity under the rubric of primary open-angle glaucoma? In fact, the name normal tension glaucoma implies that a measurement that is intraocular pressure itself, can be used to differentiate these entities. In the literature, this is sometimes used to differentiate these two disorders into pressures greater than 21 and less than 21. In reality, can intraocular pressure be used to differentiate NTG and POAG? The reality of intraocular pressure measurement and our knowledge about it in 2021 is that true intraocular pressure can only be obtained by cannulating the eye and measuring the actual intracameral intraocular pressure. Transcorneal IOP measurement, as we currently do it, is not a true intraocular pressure measurement and is affected by many factors. Examples include corneal thickness or hysteresis. All tonometers that we use have human or instrument error, and a single intraocular pressure measurement is insufficient to assess the true range of intraocular pressure in a glaucoma patient. Goldmann tonometry is our reference standard, but not a gold standard, and certainly not ground truth. We all know that there is no perfect tonometer. In fact, an inaccurate measurement cannot define two different diseases. So can IOP be used to differentiate NTG and POAG? I don't think we can do that. Secondly, can risk factors be used to differentiate these two different entities? There are a variety of risk factors, ocular and systemic, for patients with glaucoma. These range from the intraocular pressure factors that we're very familiar with, intraocular peak, mean, fluctuation, and so on, and other ocular risk factors such as biomechanics and retinal ganglion cell health, and then systemic factors such as aging, perfusion, central nervous system factors, and our genetic makeup. Sometimes we have a tendency to link or group these risk factors into the categories of POAG and NTG. This is one way that this could be done, but I think most of us would agree current knowledge suggests that all of these risk factors affect each of our glaucoma patients in perhaps a different way. There are some patients for whom intraocular pressure factors may play a more prominent role. Others may have problems with laminar cribrosa or ocular perfusion, but they all contribute to each of our patients as they age. And age itself is a strong risk factor for the progression of the disease. Some of these risk factors may change over time. Patients may develop migraine or myocardial infarction, or their hypertension may be overtreated, or they may develop atrial fibrillation, all of which lead to worse perfusion. This leads to worsening of disease over time and continued progression. Worse perfusion may also affect other structures. For example, the microcirculation of the retinal ganglion cell or surrounding the retinal ganglion cell may be altered. This may also affect tissue biomechanics at the level of the lamina cribrosa or the surrounding parapapillary tissues. These in turn worsen the disease process. Aging, of course, affects all of us and affects all of the different parameters which are affecting our patients. In fact, aging worsens almost all of these different factors and exacerbates them over time. So each of our patients experiencing these factors experiences, as I mentioned, in a different way, and has a different compendium of risk factors that affect their individual risk and their disease progression. So can these risk factors themselves, which we'll hear about later during this symposium, be used to differentiate NTG and POAG? The answer is they affect all of our patients in different ways, and we can't differentiate these entities based upon the risk factor assessment. So can we use the appearance of the optic nerve and visual field to differentiate NTG and POAG? Many of the luminaries in our field, one of the founders of the World Glaucoma Association, Professor Greve and Stephen Drance, over time, over many years, evaluated the appearance of the optic disc, perhaps dividing the disc into 4 glaucomatous subtypes: focal ischemic, senile sclerotic, myopic, or generalized enlargement. And certainly for research purposes, this may be of interest, but many of our patients, as you see on the right, are affected, have optic discs that have multiple components of these different appearances. that we know much more about glaucoma than just the clinical appearance of the optic disc. We have detailed information about retinal ganglion cell structure and axonal structure, different information about the change in the appearance of the parapapillary optic nerve and optic nerve complex, the lamina cribrosa, and changes that occur in the brain. We and others have looked at the visual field and how the visual field might change over time in high tension versus normal tension glaucoma, and also looked at retinal nerve fiber layer. Many of the people listening to this talk and in the audience have performed numerous studies looking at these different characteristics. However, the reality for the single patient in front of us suggests that it's very difficult to differentiate patients on this basis. For example, does this patient with progressive rim loss, PPA enlargement, and disc hemorrhage over a 20-year period have normal tension glaucoma or primary opening glaucoma? If I told you the intraocular pressure was 30, would you be surprised? Or if I told you the intraocular pressure was 15, would that surprise you? Here's another patient with a focal inferior notch and paracentral loss. Is this NTG or POAG? Does the imaging help differentiate these two entities? We know from experience that many of these patients exhibit characteristics similar characteristics across the entire glaucoma spectrum. So the appearance of the disc and the visual field cannot help differentiate these two clinical entities. I think we need to look to the future. If the pandemic has taught us anything, it's that our scientific acumen has advanced tremendously over the past few years. And if we can create a vaccine against COVID within a year, I think that we can make tremendous advances in the evaluation of glaucoma. Our technology is rapidly advancing, where we can look at the microvasculature of the retina and the optic nerve. We can carefully examine organelles and their function, such as the mitochondria on your right, and create a better understanding of tissue metabolism and oxygenation and the role that this plays in the disease pathophysiology. I think the greatest advance, of course, will come from our understanding of human genetics and how we apply the genetics in the field of applied genetics to our glaucoma patients. So if this is how we currently look at this condition of NTG and POAG, this disease spectrum, in the future, we'll be able to dissect the forms of primary open-angle glaucoma using genomics and precision medicine into its genetic subgroups. For example, we can do this with myocillin for juvenile glaucomas, optineurin for some forms of normal tension glaucoma. But there are many, many others. I list them here. Some will be individual genes, and then there'll be other groups of genes that work together to differentiate these diseases into their subtypes for the best possible classification. That future is now. Here is a review article by Drs. Wiggs and Pasquale from 2017, describing some of the loci that were recently discovered for primary open-angle glaucoma. So lastly, will precision medicine be used to differentiate normal tension glaucoma and primary open-angle glaucoma and all the different subtypes in between? The answer is quite possibly yes. So in conclusion, NTG and POAG are part of the same clinical spectrum. They are characterized by pressure-dependent and pressure-independent risk factors that vary from individual to individual, but each individual suffers from components of each of them. They're all linked by being a pressure-sensitive optic neuropathy, and pressure lowering slows the disease progression across the entire disease spectrum.
Hello, everyone. My name is Makoto Aihara, Tokyo University. It is my great pleasure to introduce Professor Dr. Joost Jannes for this presidential symposium of normal tension glaucoma. He is a comprehensive ophthalmologist and clinical scientist, chairman of the Department of Ophthalmology, Heidelberg University, Germany, a member of the German Academy of Science, Glaucoma Research Society, Macular Society, Retina Society, and the Academia Ophthalmologica Internationalis, and honorary member of the French Ophthalmological Society and Asia Pacific Vitreoretina Society. And he received the International Gold Award of the Chinese Ophthalmologic Society. Today, he will talk ocular blood flow and translaminar cribrosa gradient in the pathogenesis of normal tissue glaucoma.
Dear chairpersons, ladies and gentlemen, it's a great honor and pleasure for me to present this talk on ocular blood flow and translaminar cribrosa pressure gradient in normal tension glaucoma. Please see here my financial disclosures. High pressure and normal pressure glaucoma can have a strikingly similar optic nerve head morphology. For example, in these two patients with a deep and steep cupping, those types of glaucoma show localized retinal nerve fiber layer defects, and all types of glaucoma, high pressure and normal pressure glaucoma, are characterized by a loss of neutral rim and a widening and more or less deepening of the optic cup. And all types of glaucoma, high and normal pressure glaucoma, show development and enlargement of parapapillary beta zone, quite in contrast to any vascular-induced optic neuropathy. So that there are clear morphological differences between glaucomatous optic neuropathy and any vascular optic neuropathy. This makes one look beyond the lamina cribrosa into the backyard of the eye, realizing that behind the eye, the orbital cerebrospinal fluid pressure is a real counterpressure against the intraocular pressure and one of the determinants of the so-called translaminar cribrosa pressure difference. And the notion now may be that patients with a normal IOP may perhaps have a low orbital CSF pressure, leading to an increased translaminar cribrosa pressure difference. This notion was favored by a landmark retrospective study by Berdal, who showed that patients with open-angle glaucoma had a lower CSF pressure than non-glaucomatous patients. And it was favored and supported by a clinical landmark study by Ning-Li Wang's group, in which patients with normal pressure glaucoma had a lower CSF pressure and a higher translaminar cribrosa pressure difference compared to a control group. Interestingly, individuals with ocular hypertension had a relatively high CSF pressure. Also interestingly, in the control group, CSF pressure was associated with intraocular pressure and with higher blood pressure. So that the notion was that IOP blood pressure and CSF pressure are correlated with each other under physiological conditions, probably with the heart as energy pump as a leading pressure. In the clinical study, the amount of optic nerve damage was associated with all three parameters. In the multivariate analysis, however, it was only associated with an increased translaminar cribrosa pressure difference. Interestingly, also in the control group, higher CSF pressure was correlated with higher body mass index and with younger age. This may fit with the observation that in Japan, the majority of patients with open-angle glaucoma have normal pressure glaucoma, with these patients usually being older and being very slim, perhaps having low CSF pressure. In another study by Ning-Li Wang's group, patients with normal pressure glaucoma had a very thin, relatively thin, orbital CSF space, a surrogate of a low orbital CSF pressure. And in an experimental monkey study, with surgical lowering of CSF pressure, the monkeys developed an optic nerve damage, not really with a marked optic cupping, but with a clear loss in optic nerve fiber number. Using the data of the control group, a formula was composed to estimate CSF pressure, and this formula was put into the data file of two population-based studies. And in both studies, Beijing Eye study and Central India study, first, higher estimated CSF pressure was correlated with higher IOP. And in both studies, the optic nerve damage was associated with the translaminar pressure difference and not with IOP in the open-angle glaucoma group, in contrast to the angle closure glaucoma group. And ocular hypertensive individuals had higher estimated CSF pressure. There were also some side effects. The thickness of the choroid was correlated with the higher CSF pressure. The incidence of central vein occlusion in the Beijing eye study was correlated with higher CSF pressure. The incidence, prevalence, and severity of diabetic retinopathy also correlated with the higher estimated CSF pressure. And the vein diameter, but not the artery diameter of the retina, was correlated with the estimated CSF pressure. In addition, there may be a dynamic aspect, as shown by this study from Bill Morgan, suggesting that the pressure wave from the heart first arrives in the CSF space in the brain and then in the eye, so that during the ocular pulse phase, the translaminar glucosa pressure difference may undulate, what may be physiologically and pathophysiologically of importance. And of course, if the CSF pressure plays a role, also body positions may play a role. And in this study, the IOP relatively quickly changed according to the change in the body position. This has not been estimated yet with the CSF pressure, and any change in the dynamics between CSF pressure change and IOP change in dependence of the body position, of course, may be of pathophysiological importance. The notion of the role of CSF pressure in glaucoma was contradicted by the study by Lindane and was supported by some case series studies on patients with low CSF pressure and also supported by the Korean National Health and Nutrition Examination Survey. So that, based on the clear morphological difference between glaucoma and vascular optic neuropathy, one may assume that besides a number of parameters, the translaminar pressure difference perhaps may play a role, so that in glaucoma either the IOP may be elevated or the CSF pressure in the orbit may be low, for example, due to a blockade of the CSF in the optic nerve canal, or as in typical patients with Flammer syndrome, with low blood pressure, low IOP, there may also be a low CSF pressure, and that unfortunately the low blood pressure is correlated with a more marked reduction in CSF pressure than reduction in IOP, so that the translaminar pressure difference gets elevated, leading to a barotrauma to the optic nerve, explaining the morphological similarities between high and normal pressure glaucoma. So that again, the clear morphological difference between glaucomatous and vascular associated optic neuropathy contradict a primary role of a vasculopathy in the pathogenesis of glaucoma, and perhaps the answer may be the CSF pressure in the orbit. Thank you very much.
It's my great pleasure to introduce our next speaker, Professor Ki-Ho Park from the Seoul National University College of Medicine. Professor Ki-Ho Park is a very well-known figure in ophthalmology and to all of us in the world of glaucoma. He's the president of the Asia Pacific Glaucoma Society and the Korean Ophthalmological Society. He's the incoming president of the Glaucoma Research Society and serves on the board of governors of the World Glaucoma Association. He's also the associate editor of the Journal of Glaucoma, among many other journals, and he has published widely in the field, expanding our knowledge on a range of topics, including today's, which is what we look forward to hearing from him on systemic and ocular risk factors for normal tension glaucoma. Professor Ki-Ho Park.
It is my great honor to be invited to the Presidential Symposium. This is my financial disclosure. My talk will cover systemic and ocular risk factors in normal tension glaucoma. To avoid overlap with other speakers, I will present aberrant immunity along with inflammatory cytokines and systemic vascular abnormality and IOP fluctuation. The aberrant immunity is closely associated with inflammatory cytokines in nervous system. The first evidence of aberrant immunity in glaucoma has been proposed by Wax showing antibody against the HISHA protein 60 in NTG patients. In a rat model, HISHA protein immunization induced retinal ganglion cell loss resembling human glaucoma. Further, optic nerve head glial cell is known to be a key player of immune responses in glaucoma. In human glaucomatous retina, IgG autoantibody accumulation has been demonstrated. Helicobacter pylori infection is known to be associated with glaucoma, in which autoimmune response and inflammatory cytokines are one of the important mechanisms of the optic nerve damage. Our group has investigated the association between H. pylori infection and NTG in Korea. H. pylori serology positivity in NTG was over 70s, while the percentage was in 50s in control group, with the odds ratio between 2.05 and 1.73. Breakdown of blood-brain barrier is essential for the antibodies and T cells to attack neurons. In the eye, the indicator of blood-brain barrier breakdown is disc hemorrhage and parapapillary atrophy. I'll skip these risk factors to avoid overlap with other speakers. Systemic vascular abnormalities in NTG have been reported. From a study in Hong Kong, silent cerebral infarct has been demonstrated to be associated with visual field progression in NTG patients. The association between the retinal nerve fiber layer defect and cerebral small vessel disease have been shown by our group as well. In a Korea National Health and Nutrition Examination Survey study on the risk factor of POAG, in which 95% of POAG are NTG, systemic hypertension and non-overweight were associated with POAG in the Korean population. We have to look at the IOP fluctuation in NTG as well. It is well known that the habitual IOP increase during sleeping time. In glaucoma patients with asymmetric visual field loss, we investigated the IOP difference in lateral decubitus position. Even though this was a cross-sectional study, the worst eye showed higher IOP in worst eye dependent lateral decubitus position than better eye. And if the eyeball was compressed against the pillow in the lateral position in healthy eyes, the IOP increased even higher. So if the NTG patients are sleeping in the prone position like this, their pressure will be higher during sleep. The relationship between preferred sleeping position and asymmetric visual field loss has been studied. Among asymmetric NTG patients who preferred lateral position during sleep, 66% preferred worse eye-dependent lateral position. Among asymmetric high-tension glaucoma patients who preferred lateral position during sleep, 72 preferred worse eye-dependent lateral position. 24-hour IOP fluctuation in NTG has been studied using rebound tonometer. The mean peak IOP was significantly higher during nighttime facing at home compared with daytime facing and clinic IOP measurements. Contact lens sensor measures ocular dimensional changes related to IOP. It is telemetrically powered and data is wirelessly transmitted from the lens to the antenna that is applied adhesively around the eye. The 24-hour fluctuation of IOP-related profile was measured by contact lens sensor in the NTG group. The IOP was significantly greater than that in the non-glaucoma group and the peak time was more frequent at night. 24-hour IOP-related patterns was investigated in eyes with NTG and healthy controls with contact lens sensors. 24-hour measurement of IOP-related signal, body position, and blood pressure were monitored. Contralateral eye IOP was measured using rebound tonometer. The eye of trial was switched on day 2. The IOP-related pattern by contact lens sensor was similar to the IOP by rebound tonometer in the contralateral eye, and the IOP of the same eye measured on the next day. The standard deviation of the 24-hour contact lens sensor measurements were significantly greater in NTG eyes than in healthy controls. During sleep time, the IOP-related values were significantly greater in NTG eyes compared to the healthy eyes. This is a case showing mostly right lateral position during sleep, and the IOP-related signal was high in that position of sleep in the right eye. Another interesting finding was that compared to the healthy eyes, NTG patients showed more lateral decubited position. And this positional pattern was reproducible, showing similar findings on the first and the second day. This is a case with asymmetric optic nerve damage with more nerve fiber loss and visual field loss in the left eye. The left eye showed higher IOP-related signal, especially during nighttime. In summary, aberrant immunity, along with inflammatory cytokine, is associated with glaucoma. Breakdown of blood-brain barrier is essential in aberrant immunity in glaucoma. This hemorrhage and peripapillary atrophy indicate the location of the breakdown of blood-brain barrier. Silent cerebral infarct or small vessel disease are associated with normal tension glaucoma. Fluctuation of 24-hour IOP-related values by contact lens sensor was greater in NTG eyes than in healthy controls. During sleep time, the IOP-related values were greater in NTG eyes than in healthy controls. NTG patients were more likely to assume the decubitus position during their sleep than were the healthy controls. I'd like to thank all the participants who contributed to our research. Thank you for your attention.
It's my great pleasure to introduce Tetsuya Yamamoto, Professor Emeritus at Gifu University and currently head of the Professor Kazuo Awata Memorial Kaijin Glaucoma Center, Kaya Eye Hospital in Hamamatsu, Japan. Dr. Yamamoto is immediate past president of the Japanese Glaucoma Society, past president of the Asia Pacific Glaucoma Society, and formerly president of the Asian Angle Closure Glaucoma Club. His primary academic interest is in the management of glaucoma, including normal tension glaucoma, primary angle closure disease, and glaucoma surgery. He has over 300 peer-reviewed publications on glaucoma and has contributed to a total of 208 book chapters on glaucoma. Professor Yamamoto, we're very much looking forward to your talk.
Thank you, Mr. Chairman. I'm pleased to be here as an invited guest. My presentation title today is Efficacy of Ocular Hypotensive Therapy for Normal Tension Glaucoma. This is my short disclosure. I'd like to present our data showing the efficacy of ocular hypotensive therapy for normal tension glaucoma today. First study is long-term outcome of normal tension glaucoma. For this study, we selected the cases, normal tension glaucoma cases, followed at least 15 years, and so on. Then we found these cases and subclassified into 3 groups. Group 1 is trabeculectomy was done during the course. Group 2 and 3 are cases in which medication was used for entire follow-up period. As you can see here, pre-intervention, I mean trabeculectomy or medical therapy, the pressure was almost similar among the 3 treatment groups. What happened after intervention? In trabeculectomy group, pressure was 14.7 millimeter mercury preoperatively and went down to 9.1 millimeter mercury. That is 37% reduction of intraocular pressure, and mean deviation slope improved by 78%. In group 2, the intraocular pressure was reduced by 20%, and MZ slope was improved by 40%. So medication as well as surgical treatment help stabilizing visual field of normal tension glaucoma. The next study is how low should we go for normal tension glaucoma? For this study, 40 cases of normal tension glaucoma was included. They had trabeculectomy conducted, and posterior follow-up period was at least 5 years. As you can see here, pressure was around 50 millimeter mercury before trabeculectomy, and it went down to 9.4 millimeter mercury after trabeculectomy. But as you can imagine, in some cases, trabeculectomy is successful, but in some other cases, not successful. So we divide the cases into 2 groups according to the postoperative pressures. If the patient has a very low certain pressure achieved during the entire follow-up period, that case was rated success and present as a solid line, as in this one. If not, they were presented by a dotted line. As you can see, if the patient has a pressure around 10 or 9 millimeter mercury or less, the visual field prognosis very good, as you can see here. If not, some of them lose the visual field. So the target pressure for normal tension glaucoma is around 9 or 10 millimeter mercury or less. Next topic is efficacy of trabeculectomy in cases with very low intraocular pressure. In this case, preoperative pressure equal to 12, or equal or less than or equal to 12 millimeter mercury. For this study, we enrolled normal tension glaucoma with the pressure less than or equal to 12 millimeter mercury, and we found these cases. Of course, as you know, we don't do trabeculectomy in these cases if the patient has a very low pressure, 10 to 12 millimeter mercury. But if they have a very severe visual field defect or threat to fixation, we have to do trabeculectomy. So we did trabeculectomy in 90 cases of with very low pressure and followed 6.1 years in average. As you can imagine, this is a preoperative central 10-2 field of these cases. As you can see, that all of them have threat to fixation and threat to the visual acuity. So what happened after trabeculectomy? As you can see, the pressure was 11.2 millimeter mercury before trabeculectomy, and it went down to 8.0 millimeter mercury 1 year after trabeculectomy and 8.4 millimeter mercury at the last visit. And what happened in their visual acuity? Of course, some of these cases lost visual acuity because they have that threat to fixation. But if we keep them and keep their pressure less than or equal to 9 mmHg at all times, the visual outcome of visual acuity is very good, as you can see here. So the trabeculectomy is helpful in cases with very low pressure. Final topic today is what happens if pressure is maintained ideally after trabeculectomy in normal tension glaucoma. Of course, nobody knows the ideal pressure for normal tension glaucoma or other cases of glaucoma, but in collaborative normal tension glaucoma study, 30% treatment help maintain the visual acuity. But as you can see here in this slide, the 20% of treated case of normal tension collaborative normal tension glaucoma study group lost visual field. Why it happened? There are three reasons. One is physiological loss of ganglion cells. Second, intraocular pressure independent risk factor exists. Third reason is the intraocular pressure reduction is not adequate. As you know, that the trabeculectomy with mitomycin sometimes result in very low pressure, and it may be ideal in some cases. So we try to find these cases. I mean the normal tension glaucoma, done trabeculectomy, then the pressure was maintained at very low level. For this study, this is the selection criteria of that study. We selected normal tension glaucoma with postoperative no treatment was done, and also average intraocular pressure was less than 10 mmHg, and at least 30% IOP reduction was achieved, and that low pressure was continued over a 10-year period. Of course, the number of these patients was so small, but we found a total of 16 cases of such cases, and the preoperative pressure was 14.8 mmHg and ranging 12 to 18 mmHg. The pressure went down to 7.0 mmHg, ranging 5.5 to 8.8 mmHg, and that low pressure was maintained for 19.5 years in average. So what happened in these cases? This is the main result of this study. As you can see, all patients in all patients except one case, visual field was maintained, and the average MD slope postoperatively is minus 0.04 decibel per year in cases, except one case, which showed the minus 0.41 decibel per year progression. But it's very wonderful result, I think. So, as you know, this is again the normal tension glaucoma study result. Then I shortened it. I put our result on it using the same success criteria adopted in the CNTGS. Although we cannot calculate the statistical significance between two groups, but there seems to be a difference between ideally treated group and treated group of CNTGS study. So, my conclusion is that visual fields almost stabilized in the majority of the cases when the pressure was maintained to be 10 mmHg or less for over 10 years by trabeculectomy. This is my summary and conclusion. So intraocular pressure lowering is effective in stabilizing the visual field of normal tension glaucoma, and the target pressure is less than or equal to 10 mmHg. Thank you very much for your kind attention.